Good afternoon. My name is Dr. Clement Nzuka. I'll be talking to you about, the problems or the trouble at the junction. The junction I'm talking about is the AV node. I'm going to talk about problems at the AV node, so to say. What is AV node? Atrioventricular node. This is the second station. The first station where an electrical signal is actually released. We said it is the SA node, the sinoatrial node, right on top of the right atrium. Find it there, and it releases an electrical signal. And this electrical signal is there to depolarize a polarized myocardial cell. All myocardial cells are polarized. Now, as a prerequisite for contraction, they need to be depolarized. So when they are depolarized, the wave of depolarization moves from this SA node, and it moves and it is propagated right through the atria, and all those converge towards the AV node. The AV node being the junction, just like railway tracks. Railway tracks, they converge towards a junction. And the junction this time is the AV node, or the atrioventricular node. Now, what is the first problem there? In fact, it is not a problem. That's what needs to happen. There has to be a delay when it gets in there. When in the junction, all those electrical impulses must get delayed there, just for the completion of the job that was done by the atria. For the completion of the job, in other words, for the complete contraction, pushing all the blood from the atria to the ventricles. But now that must happen and it must come to an end. So there's a little bit of delay. But if this goes on, it goes on, we get a delay which is more than 200 milliseconds. So that then is regarded as the first degree AV block. It's not supposed to be less than 200 milliseconds. And then if it is more than 200 milliseconds, it is now a first degree AV block. So the first degree AV block is not really a block, it's actually a delay. Now we come to the second degree AV block. Second degree AV block, let me skip it because it's a bit complex. Let me talk about the third degree AV block. The third degree AV block is a complete block. It's a complete heart block, in that no electrical impulse, no P wave. You know, when there's those electrical impulses, when they converge towards that junction, they form what is known as a P wave. During the the propagation through the atria, they develop something called a P wave. A P wave. The P wave is the one that is being prepared to go through the AV node so that it can go to the lower levels. Right. So now the P wave, it's important to recognize it as a P wave, because now nothing goes through. No electrical impulse goes through. No electrical signal goes through. No P wave goes through the AV node when it's a complete heart block. In other words, a third-degree AV block. Third-degree AV block, nothing happens. So what happens then? What are you saying? Are you saying then the patient dies or something? No, not at all. What happens is, if the SA node fails to deliver an electrical signal, it fails. The subsequent, or the lower junction, that is the AV node, is going to take over and release, but at a lower, slow rate. It will release. But if the AV node fails as well, like now, it fails as well, the ventricle has got to take over at a very slow rate. Has got to take over and release everything to the Purkinje fibers, the ventricles, and then at least there has been a bit, though it was very, very slow. Right. Now that we have said there's a complete heart block in this the third degree third degree AV block. There's nothing going through. Now let us come to the second AV block. What happens to the second? Why did you say it's complex? It's complex because it's divided into 3 heart blocks. 3. One, the first one, it's where there's a prolongation of the PR. You know, maybe I should explain this one. When the P wave goes through the AV node, it generates what is known as a QRS. A QRS complex. And that QRS complex is the contraction of the ventricle. That's the actual beat. So there's a P wave and then the R wave. So the PR interval is an important interval to define this block that I want to talk about. That is the second degree AV block. The second degree AV block is characterized by a prolongation of the PR interval. So there's a progressive prolongation of the PR interval. Prolonged. This progressive prolongation of it is telling us that whatever is wrong is intranodal. It's inside the AV node. Whatever is wrong. And this is referred to as type 1 second degree AV block. Type 1. That's very important to know, because it implies that we can do something about it if it's intranodal. We can think about the type of drugs which are responsible for this. Are they the calcium channel blockers, like verapamil, like diltiazem or cardizem? Are they beta blockers, like atenolol, whatever? So we can play around with these to try and address the problem of type 1 second degree AV block. What happens to type 2? Type 2, the PR interval is not prolonged at all. Otherwise, it's constant before a dropped beat. Even with the type 1, there's a progressive prolongation before a dropped beat. So there's a dropped beat. There's a beat that's not there. Right. That's why we call it a block, because the beat has been blocked. So prolongation of a PR interval prolongation, 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 and then a drop beat. And that is type 1 second degree AV block. Type 2 second degree AV block is like this. The PR interval is constant, kept constant, 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 dropped beat. Now, this is saying something to a healthcare worker. It is saying, the block is infranodal instead of being intranodal. So there's no question of drugs being involved in this. In other words, you can't think of a beta blocker, think of a calcium channel blocker. No. It doesn't matter what you do with those drugs, whether you reduce or maybe you take away those drugs or whatever. It's not going to make a difference because the problem is infranodal. It's beyond the AV node. So in other words, from the bundle of these to the Purkinje fibers, right? So it's beyond, it's infranodal. And this is what calls for your attention. To say that with this one, I'm not going to waste time with drugs and stuff like that. What I'm going to do, I'm going to send this patient away to the cardiologist, to the electrophysiologist to go and they must think of pacemaker. Pacemaker. The management is a pacemaker. The management is a pacemaker, nothing else. And that's type 2 second degree AV block, as opposed to type 1 second degree AV block, where there was a progressive prolongation of the PR interval and then a drop beat. With this one, it's constant, 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 drop beat, and implying that this has taken place or has occurred infranodally. Right. What is the last one? The last one is what is known as what is actually happening. Maybe I should explain that. You get a P wave. You get another P wave. Remember, when you have a P wave is supposed to generate a QRS. That's the normal. P wave, QRS, and then a T wave, which is repolarization. This one is a P wave, where representing the depolarization of the atria. And then this has got to go through and produce a QRS, in other words, a contraction of the ventricles. That's the norm. But now, with this block, you have a P wave, another P wave. The P wave, the first one didn't go through, even the second one doesn't go through, or even the third one doesn't go through. Then you start seeing a QRS. This is odd. This is what is known as high grade. It's called high grade. This block is known as high grade, or advanced. High grade or advanced. This one, it cannot be managed by medication, whatever. The patient has to go for a pacemaker. So what we need to take home is that there are 3 types of second degree AV block. You got type 1, where there's a progressive prolongation of the PR interval, drop beat. And then you've got type 2, where there's constant PR interval, constant, drop beat. And then this one is saying to you, healthcare worker, send the patient away to the electrophysiologist, send the patient away to the cardiologist for them to manage this using a pacemaker. So you need a pacemaker with this one. There's nothing you can't play around with drugs like beta blockers, calcium channel blockers, your verapamil, your diltiazem, or cardizem. No, you can't do that. It's a waste of time. That's when you are treating an intranodal problem. Intranodally. That's so the first, second degree AV block. No, I'm talking about second degree AV block. When you are in the second degree AV block, you have the progressive prolongation. That's type 1. Type 2, it's constant, and then a drop beat. And that patient has got to go for. Now, the last one is advanced or high grade. This one, you have a P wave. You never, you have another P wave. You can have a third wave. You can have another. You can have, but you have only one QRS generated. So what happens to this? So nothing. So say they didn't go through. They didn't go through. Only one went through to generate a QRS. That is high grade, is advanced. That patient has got to go for. Has got to go for a pacemaker. This is the trouble at the junction. The trouble at the junction. It could have been caused by, you get it, for instance, you don't get it with young guys, you get it with old age. As people are aging in their 60s and the rest, the old age, from wear and tear. You could have got it even from a heart attack. Like, for instance, if the heart attack goes through the right coronary artery, it can form another type of a second degree AV block, which I don't know whether type 2 or type 1. If it's on the left, left anterior descending artery or left circumflex. Remember, I always say something about these fuel pipes, because these are the fuel pipes. They carry, the fuel to energize what? To energize the contraction of the heart. In other words, the myocardium, right? Those are the ones. Maybe it's on the left. And it will form another. So I'm trying to explain the different types. How do you get the different types? It means it is the route that was followed that determines which one will be formed, right? So we don't know exactly, but what we know, something went wrong. Myocardial infarction or heart attack coming from which side? It's important, the direction now, so as to generate what type of a block. That type of a block, as we know that the second degree AV block has got different types of block. Even when we don't get anything, we know. In other words, when we don't get one electrical signal going through the AV node, we know that we've got a complete heart block, and that complete heart block can only be managed by pacemaker. It can only be managed by pacemaker. Right. So these are wonderful and to know, so that management should be easy. It would be nice to talk to your senior doctors, your cardiologist, or your physician, at least knowing that the diagnosis I'm making, this is second degree block, type 1. Why do you say that? Because there's a prolongation of there's a progressive prolongation of a PR interval. You're motivating it. That's very good. Before I drop this topic, I would like to say something just about, remember, all along I've been talking about chest pains And the chest pains that I've been talking about, they are chest pains from the heart. Call them angina. Okay, so the anginas. So angina pectoris. Angina pectoris, we said it is because of an obstruction. Is obstruction. In other words, the demand and the supply equation are not. There's an imbalance. The supply is being affected by an obstruction. But now I have this one patient. The scans have been done. The X-rays of the arteries have been done, but there is nothing is found. In other words, there's no abnormality found in the atria. In the arteries. The arteries there's no atherosclerosis as we were talking about when we were doing the MI, the myocardial infarction, or the heart attack. We're talking about the development of atherosclerotic plaques, those atherosclerotic plaques which were developing, and they would be picked up using an X-ray or a scan of the arteries. Now those tests have been done, and the arteries are clean, but the patient is having a pain. The patient does not believe the doctor because the doctor is saying, no, your arteries are okay, but I think my arteries have something. Why do I have pain? Because I know all the other patients who have arteries which have those atherosclerotic plaques. All those, they have a chest pain, and they have a chest pain from the heart, and they have an angina, so to say. Others develop from the stable angina, they go to an unstable angina, and they develop a myocardial infarction or a heart attack. I mean, this is the pain that I'm experiencing, and you're telling me that my arteries are clean, my arteries don't have a problem, there's no abnormality. I don't believe you, doctor. I don't believe. And the patient is rightfully not believing. That's right. It is right for the patient not to believe because the pain is there. This is given a special name. We call it syndrome X. Syndrome X has got that problem. And syndrome X has some explanation from the medical fraternity. Medical fraternity say, man, you get this characteristically with those patients who are ladies. You do get it even with men, but with ladies to a greater extent. You get it with ladies who are at their 40s, 45, 50, 60. You get them there. And at that critical age, that's when the estrogen levels go down. Estrogen. They give it as an explanation for syndrome X. We don't know, we haven't arrived at a correct diagnosis to say it is this that causes, but the medical fraternity, they are making all efforts to try and explain how syndrome X arises. In other words, and pain from the heart, but the arteries are clean. In other words, there are no atheromas being formed to form atherosclerosis, a condition that narrows the lumen of the arteries. And the arteries I'm talking about are the fuel pipes. The fuel pipes, you remember on the left we have left anterior and anterior descending artery, and which is right in front, and it's feeding the frontal area of the heart. And you've got this left circumflex which goes around, wraps around the heart. It wraps around the heart and it feeds even the base of the heart. And we said these are vulnerable. We said these are vulnerable. And they are vulnerable because to what? To a shortage of blood because of the obstructions which are actually formed there. And then on the right, you've got a right coronary artery. Also, it's very much vulnerable. But now, we are finding that all these fuel pipes are clean. In other words, there are no atheromers being formed to narrow the lumen, but the pain is there. And that is why this is called syndrome X. Thank you very much. Thank you very much. Thank you very much.